We're going to talk about concepts in chest x-rays and chest radiography during our next chapter. And along with that, we're going to evaluate patients with presenting with acute respiratory compromise and distress, just so you could see how the workup is done and how the chest x-ray really plays a big role in that. But let me start with some basic concepts first and some relative questions that you could find on the boards. And here's the first one. A 26-year-old man has a 2.5 centimeter calcified nodule in the right lung found on a routine chest x-ray. Now he was doing something, he got the chest x-ray. We don't get routine chest x-rays. It was a routine chest x-ray because he was employed, his employer asked for it, and it was a routine chest x-ray because everybody got their x-rays in that sense. But I don't want you to think that a chest x-ray is part of a routine physical. It's not. This patient got it because of the stuff that he was doing for work. This person has no complaints. He has never smoked, and his exam is totally unremarkable. What is the next step in this case? And I could tell you right now, the first step that you would do in this patient is to look for old chest x-ray he may have had years before or as a child, to look and confirm that that pulmonary nodule has been there, or if it wasn't there, now it becomes a different story. Generally, though, the first test to do is always to look for a pulmonary nodule on the old chest x-ray. So what is the story with pulmonary nodules, and how do we and where do we go after getting an old chest x-ray? So getting the old chest x-ray is the first thing, and if we find it there, if we find it on the old chest x-ray and it's been more than a couple of years and it's been stable, then most of us say this is, a benign pulmonary nodule, especially in this patient who's a low-risk patient, and we don't do anything about that. We may do an additional chest x-ray one more time to confirm that it doesn't change in size, and then really we don't do anything beyond that if it's been more than a couple of years since the old chest x-ray. Now, some people have asked me, well, a pulmonary nodule, if you find it on the chest x-ray, okay, it's not lung cancer all the time, but what is it? And the answer is, most of these are old lung infections. Sometimes in certain parts of the United States, for example, in the Midwest, people get blastomycosis. In the West, they get coccidiomycosis, fungal infections. Histoplasmosis is common in the South and some parts of the East Coast. So an old infection could do that. Once a patient, though, if we find a pulmonary nodule and we don't find an old chest x-ray, or the old chest x-ray doesn't show the pulmonary nodule, then the next step in evaluating this patient is to decide whether he or she is at low risk or high risk. And depending where you stratify this patient, the workup is totally different. So let me give you a couple of the stuff on this. A low-risk patient is a patient that has no smoking history, is relatively young, basically less than 45 years of age, like our patient, and has no complaints at all. What do we do with a low-risk patient? Believe it or not, we don't do anything more than get a follow-up chest x-ray every about 3 months for 2 years. And then if the pulmonary nodule is stable, then we stop the follow-up and we say this is a benign pulmonary nodule. So let me say this again. In a low-risk patient, what do I mean by low risk? Young patient, generally less than 40 to 45 years of age. A non-smoking history, they have to be non-smokers, and no complaints, no symptoms, that patient is considered, for your purposes, a low-risk patient. And what do? We follow up with chest x-rays every 3 months for 2 years, and then if that pulmonary nodule doesn't change in size, then what we do is forget about it and we say it's a benign pulmonary nodule. On the other side of the coin are the high-risk patients. Now, these are generally people over 45 or over. They have a significant smoking history, and we'll talk about this later in the pulmonary section, but the lung cancer is associated with tobacco, with smoking. So now this patient is over 45, has a significant smoking history. That is a high-risk patient. And what you do for this patient is, I know it sounds a little bit aggressive, but you do an open lung biopsy and remove the nodule. They will be specific that it's usually a peripheral pulmonary nodule. They're trying to help you out there, trying to tell you, look, if you do a bronchoscopy, you're not going to get to it anyway. You're not going to get the results you want. So let me go back and explain this a little bit. The high-risk patient has a new pulmonary nodule, or you don't have an old x-ray showing the same pulmonary nodule, or you don't have a chest x-ray in the past at all, that patient has cancer until proven otherwise because of his or her history. If you do a bronchoscopy on that patient, then you may get a non-diagnostic inflammatory process. Because a bronchoscopy is done, it's a blind biopsy, sometimes the yield is not good and you may not get to the cancer and make the diagnosis. So even if the bronchoscopy is negative and it shows just inflammatory cells or inflammatory process, that patient could still have cancer. So what I'm really trying to tell you is no matter what those results from the bronchoscopy are, you're going to still have to get lung tissue and remove the nodule. If the bronchoscopy is positive, it shows cancer, you're going to have to do an open lung biopsy and remove the nodule. So you're going back to the same case that we did here. You're going back to the same scenario. So please, in a high-risk patient, don't go for bronchoscopy first. Don't go for a CAT scan in terms of deciding if this is cancer or not. You may go for a CAT scan to see how big the nodule is, where the extent is, to see if there's other nodules you need to biopsy. But to tell you if this is cancer or not, the CAT scan can't tell you that. The bronchoscopy likely will not tell you. So what do you do in a high-risk patient with a new onset pulmonary nodule? Then you go for an open lung biopsy and you remove the nodule. In clinical practice, in reality, sometimes, so we don't do a more aggressive procedure, which is the open lung biopsy, in certain nodules that are centrally located, so now you have a better access with the bronchoscopy, you may be able to say, okay, let me try the bronchoscopy first, see if I could get a good yield, see if I could diagnose the cancer this way, and then try to forego the open lung biopsy. But they're not going to ask you that. I'm telling you again, they're going to give you a peripheral nodule, and a peripheral nodule in a high-risk patient is cancer until proven otherwise. You go for an open lung biopsy. Again, just like the bottom of the slide refers to it, be careful because bronchoscopy results in high-risk patients are non-diagnostic commonly because it is a blind biopsy. And in the end, whatever you get on that biopsy, whether it's cancer or not cancer, you're going to still have to do an open lung biopsy and remove the nodule. A lung nodule may be one of the first, the few times that you have a resectable lung cancer. So please don't miss that. Again, what do we do in a high-risk patient? We do an open lung biopsy and remove the nodule. What do we do in a low-risk patient? They're not smokers, they're young. We follow up the chest x-ray every 3 months for 2 years and then stop after that, do nothing more. So that's the pulmonary nodules. Also, please, please be careful. There's some, I know people ask me all the time, and there is some mention, the type of calcification that you see on the CAT scan or the chest x-ray may be more malignant or less malignant related. So what I'm saying is, so for example, some people with what are called popcorn calcifications, spickled patterns and stuff like that may be more or less associated with malignancy. You will not have to know that, because the bottom line is, even if there's calcifications there, even if they look less malignant, more benign, you're still going to have to make sure that this patient doesn't have cancer in a high-risk patient, so you have to remove the nodule. Be careful of that. They could try to tell you this patient has popcorn calcifications or something calcification. It doesn't really matter. In the end, you're going to have to get tissue and you're going to have to remove that nodule. So please be careful on that. So x-ray first and then stratify the patient. Are they low risk or high risk? And then decide what to do based on which category they fit into. In real clinical practice, you will see the third group, which are intermediate patients, and that's probably most of the patients that we see. They don't fall totally into low risk group, and they don't fall totally in the high risk group. They fall into an intermediate risk patients, and then those patients you could do other stuff, maybe bronchoscopies, CAT scans and stuff like that, but they will not give you those patients because the theory behind this is they want you to know not to miss a pulmonary nodule and assume it's benign in a patient with cancer. So they're going to give you the low risk or high risk, nothing in between. The next case I want to discuss is and talk about is pleural effusion. That's another very important subject on the boards and in clinical practice because we see all the time these patients commonly being mismanaged. So here's the case. A 65-year-old man presents with dyspnea and pleuritic chest pain over 1 month. He has also noticed a 20-pound weight loss. You find decreased air entry in the right lower lobe. A chest x-ray confirms that there's a pleural effusion there. And then you do a decubitus x-ray which shows a free-flowing fluid of approximately 3 centimeters. So they did here for you the most important test, what you do first after you find a pleural effusion. And the answer is you do decubitus x-rays to see if there's free-flowing fluid. Anything equal to or above 1 centimeter on the chest x-ray, on the decubitus chest x-ray that layers out, you could go and do what the next appropriate step is, which is a thoracocentesis. So in this case here, to go back here, the next appropriate step in this case is to go and do a thoracocentesis because they've done the decubitus chest x-ray for you. Please be careful. If a patient has a pleural effusion and you do a decubitus chest x-ray and the fluid doesn't free flow, there's no free flow of fluid, so it means it's loculated. It's still an effusion, but it's loculated because it's been there for a long time maybe, or because it's infected or it's complicated. If you do a thoracocentesis in that patient, you are likely more to get complications from the thoracocentesis rather than get fluid out and make a diagnosis or confirm a diagnosis. So be careful. If a patient has a pleural effusion, right, and you do a decubitus x-ray and the free-flowing fluid is not there, there's no free-flowing fluid, you go next and you do under ultrasound-guided thoracocentesis. You don't do a thoracocentesis yourself. You talk to the radiologist. They go in with the ultrasound. They find a pocket of free-flowing fluid somewhere in there, and they do a thoracocentesis under ultrasound-guided in order not to cause any complications. But in this case, it's different. We have the typical pleural effusion. We have the decubitus x-ray showing free flow. What is the next appropriate step? Always a thoracocentesis. We should never, ever not do a thoracocentesis in free-flowing fluid, whether it's in the middle of the night when we find the patient or the next day or whatever. As soon as you find a pleural effusion, you have to do thoracocentesis always, always, and immediately. Please be careful of that because they may show you about they may talk to you about a case where you have an effusion, and they tell you you may want to wait a day or two and stuff like that. You don't want to do that. I'll explain all the scenarios, but you never ever want to do that. You want to do thoracocentesis immediately, as long as there's free-flowing fluid. And if there's not, you need to do ultrasound-guided thoracocentesis immediately also. So let's talk about effusion because this is very important. Why do we get the thoracocentesis fluid? Well, the first thing is because we want to tell the difference between a transudative process and an exudative process. That's the first and foremost thing. So, for example, a transudative process means systemic factors are involved in causing the effusion, like nephrotic syndrome, like cirrhosis, like congestive heart failure. For example, things that cause increased hydrostatic pressure or decreased oncotic pressure, like the nephrotic syndrome, you're losing albumin. So any systemic factors that cause increase in hydrostatic pressure or low oncotic pressure will cause what is called a transudative effusion. Well, think about it. If it's a systemic diseases, then the effusion is transudative, but it should also be equal on both sides, because you should have two effusions if there's systemic reasons, like low oncotic pressure. So you should have two equal effusion on both sides. Our patient here didn't have that. So right away you should be thinking, even before the thoracocentesis, I probably think what the likely cause in this case is. It's probably not a transudative effusion, because transudative effusions, they're systemic effusions caused by systemic disease, and they're equal on both sides. And we confirm that by running a couple of things on the thoracocentesis fluid. And we get the LDH from the effusion, then we get the LDH from the effusion, and we compare it to the LDH in the serum, and then the third thing that we get is the protein from the thoracocentesis fluid, and then we get the protein in the serum and do a ratio of that. So how many tests do we need to confirm a transudate? We need basically 3 tests from the thoracocentesis fluid and 2 tests from the serum. We need the LDH from the effusion, right? Then we need the LDH in the effusion, and I call this a test really, right, to basically say an LDH in the effusion and compare it to the LDH in the serum, and then the protein in the effusion and compare it to the protein in the serum. So really, we need 2 tests in the thoracocentesis fluid, right, and 2 tests in the serum. The numbers to remember is for an LDH, 200, and then the LDH of the effusion to the serum, 0.6, and then the protein to the serum, effusion to the serum, 0.5. So the way I remember it, kind of like a mnemonic, 200, 0.6, 0.5. 200, 0.6, 0.5. For transudate, you have to have all of these less than. For transudative to occur, all these parameters have to be less than. So the LDH in the fluid has to be less than 200. The LDH ratio, fusion to serum, has to be less than 0.6. And the protein ratio has to be less than 0.5. Please be careful. All these 3 parameters have to be less than for a transudative effusion to occur. Once you confirm a transudative effusion, then you say, I have to treat the primary disease. I do nothing more about the effusion. So for example, somebody that we diagnose with a transudative effusion that has congestive heart failure, you treat their congestive heart failure to minimize these effusions. You do nothing more, no further investigation of these effusions. Now compare that to an exudative process. An exudative process, there's a local process there causing either inflammation or infiltration in the pleura that cause the effusion. It's not a systemic disease. In terms of hydrostatic pressure and oncotic pressure, this is a local process. Like what? Like cancer, like tuberculosis, like an acute infection, like strep pneumo. This is also called parapneumonic effusions. So local inflammation that causes it, local infiltration from a cancer that does that. So usually with an exudative process, we see 1 effusion or 2 effusions, but one is higher than the other. So for example, our patient had a very big effusion on one side, didn't have anything on the other side. That's typical of an exudative effusion because it's local processes that cause the exudative effusion. How do we confirm an exudative effusion? Well, we did the first test, and that's the thoracocentesis. And what do we get from it? Well, we get all the LDH and the serum protein and the protein in the fluid and so forth. And now all we need is for any of the 3 parameters that we just talked about that we needed to diagnose a transudate. In this case, in the exudative process, they're usually above. So for example, LDH is above 200. The LDH ratio is above 0.6. The protein ratio is above 0.5. But here's the interesting thing. for an exudative process, all you need to diagnose an exudate is one of these being above. So if you tell me that the LDH ratio and the protein ratio is normal, but the LDH from the thoracocentesis fluid is 500, above 200, that's above 200, right? It's 500, that patient has an exudate. I don't care. I don't have to fill the 3 criteria. I need only one to be above to diagnose an exudate. Usually, they help us. They give us, so we won't have to sit on the boards and we have to do all the ratios and stuff like that. They help us out. They give us a very high LDH right off the bat. So what I want you to do is, when they give you some kind of pleural effusion on the boards, I want you to focus on the LDH, first of all. See, look at the LDH. If it's above 200, end of story. That's an exudate. I don't need to do anything more. What I need to do now is further investigate and find out what the cause is. So I want to make sure everybody's clear. What do we do when we look at the thoracocentesis fluid? The first thing we do is we look to see if the LDH is above 200. If it's above 200, this patient has an exudative process. No question asked. We don't have to look further. We have to see now what the cause is. An exudative process means we have to further investigate and find out what the cause is. So let's look at these 2 things. So I want to give you a couple of definitions and then discuss a little bit about the 2 processes again. A parapneumonic effusion is an infection in the lung, usually community-acquired pneumonia, that causes an effusion close to the pneumonia, so it's parapneumonic, close to the pneumonia, and this is referred to as a parapneumonic effusion, and this is the most common cause of an exudative process, a parapneumonic effusion. One of the most common organisms is strep pneumo, because this is the most common form of pneumonia. Then you will hear the term hemorrhagic effusion, where they took out thoracocentesis fluid and they found blood. And one of the causes of that is tuberculosis. The other cause that you need to think about that is cancer. And then the third cause is pulmonary thromboembolism with an infarct. And then the third one that you may hear about is a lymphocytic exudative effusion, and that's usually consistent with tuberculosis or lymphoma. And then the fourth one that you may hear in reference to is a malignant pleural effusion. So think about the common cancers that are related with pleural effusion. Lung cancer is related with pleural effusion. Metastatic breast cancer is related. And there's a lot of other ones. Lymphoma may be associated. But those are the 3 more common ones. Lung, breast, lymphoma, and there's some other ones. So here's some of these are some of the definitions that you may hear about. But generally speaking, the causes of exudative effusions are non-systemic causes, usually localized processes, and the 3-4 more common ones are a parapneumonic effusion. Now you know what that means. It's an infection in the lung that causes an effusion along with that. The second most common ones are tuberculosis and cancer. And then the fourth one is pulmonary thromboembolism. So those are the 4 I want you to remember. Infection in the lung, parapneumonic effusion associated with a community-acquired pneumonia. The second and third, I want you to remember cancer and tuberculosis. And then the fourth one, I want you to remember about thromboembolism. Now, the interesting thing about pulmonary thromboembolism, it's probably the only cause that could cause both an exudative effusion and a transudative effusion. So be careful, you know, if they ask you what disease could cause both a transudate and an exudate, the answer is pulmonary thromboembolism. What if they ask you about a case of a young patient coming in with shortness of breath, and then they have you do a thoracocentesis, they have an effusion, and you do a thoracocentesis and you find a transudate, but you can't find a systemic disease. They don't have nephrotic syndrome, they don't have heart failure. The answer is maybe they got pulmonary thromboembolism because that's one of the few diseases that causes both. So please look at that. Always do a thoracocentesis in these patients. That's paramount in all cases. I want to talk a little bit more about, just a little bit about pleural effusions, and you're going to see this a little bit later. There's some interesting ones that you need to know about. The malignant pleural effusion, for example, is usually associated with lung cancer. I told you that's probably number one. And then there's a couple of things that they ask us about. Well, what does this mean for if you find malignant pleural effusion? And I mean, so you did the thoracocentesis, and now you send away for the LDH and the protein, and you diagnosed if it's an exudate. And now you've got a couple more things to send out from the thoracocentesis fluid, and you could send out for the cells, the type of white cells, and you could do pathology on that. You could spin the fluid down and look for malignant cells. So malignant pleural effusion means I usually find malignant cells in the pleural effusion. And what that usually means, especially when it's related to lung cancer, is that this is unresectable. I want you to remember that. That's usually a later stage, usually stage 3B of lung cancer, and that's usually unresectable. So please remember that. So if I see a patient with a lung mass and a pulmonary, in a pleural effusion, guess what? I'm going to go and try to get to that effusion first before I even look at the lung mass with bronchoscopy or resection, because if I find malignant cells in that pleural effusion, I've got my diagnosis and I got my staging already. I know that I can't resect the lung cancer on this patient. So please think of that. So after talking about the malignant pleural effusion, I also want to tell you about a case, an important case, that relates to the parapneumonic effusions. Remember, we talked about parapneumonic effusion being the most common cause of an exudate, and I said common infections, lung infections like strep pneumo, common pneumonias, community-acquired pneumonias, are the most common cause of a parapneumonic effusion and the exudative effusion. So they may ask us about a case that goes like this, that a young patient who has fevers and chills for a couple of days and produces a lot of green cough comes to us for evaluation of this, and they look sick, they look toxic, they have a high fever, and on exam you find crackles in the right lower lobe, and you confirm this with a chest x-ray that shows a right lower lobe infiltrate, and then you have a small effusion next to that infiltrate. And they say, well, you do the gram stain from the sputum and you find gram-positive diplococci, so this is most consistent with strep pneumo, right? And they say, well, what do you do next? What's the answer to that? And most people, believe it or not, would put this patient on antibiotics, and the answer is, yeah, you have to put this patient on antibiotics, but really what they're really asking for you to do next is to do a thoracocentesis. Now, you have the diagnosis already. Why would you do a thoracocentesis in this patient? And the answer is to make sure that this is not what is called a complicated parapneumonic effusion. A complicated parapneumonic effusion means that there is the effusion itself is infected, and it kind of works like an abscess there. So even if you give this patient a lot of antibiotics, what's going to happen is you're not going to get to the infected effusion there, and they're going to spike fever, and what's worse that's going to happen is they're going to get fibrosis in the lung, and they're going to get what is called a trap lung. So a complicated parapneumonic effusion occurs in a small percentage of patients with parapneumonic effusions related to pulmonary infections, and it means that the effusion itself is infected with microorganism, and it works like an abscess, and it causes pleural thickening and a trapped lung. What is the next step into diagnosing that? Well, what is the next step that we always do with effusion is to do a thoracocentesis. Now, in this case, they're going to ask you, how do you know it's complicated? And you're going to tell them, well, it's infected. So what I'm going to do is I'm going to find the gram stain positive from the pleural fluid. I'm going to find the culture positive from the pleural fluid. I'm going to find a low pH, and that's enough to diagnose that this patient has a complicated parapneumonic effusion. And then I'm going to get my friends from the pulmonary unit or from the surgery department to come in and put a chest tube to drain this. If you don't put a chest tube in and drain it, that patient will get, like I said, fibrosis in a trapped lung, because all the antibiotics that you give this patient are likely not going to affect the effusion that's complicated. So going back to where we started from is, what do we always do after we diagnose a free layering pleural effusion? We always do thoracocentesis. Most of the times the reason to do it is to diagnose if it's a transudate or an exudate, and then to look for the different causes with looking at the cells, we're looking at the different pathology slides and so forth, and then in certain cases of parapneumonic effusions to rule out a complicated parapneumonic effusion that will need chest tube drainage because it's infected. So please remember that. Remember that and the malignant pleural effusion. We commonly get questions, clinical questions about these cases on the tests. So a little bit further down, we want to talk about evaluating patients with respiratory distress. And I know it's in the chapter of the chest x-ray, because I want to show you a couple things where the chest x-ray falls in this whole thing. And I want to really go and evaluate a patient with respiratory distress. But always first, when a patient presents with respiratory compromise, we have to think, of different processes, right? So it may be something like obstruction, like COPD and asthma. It may be also, from parenchymal lung disease, like bacterial pneumonia, like strep pneumo, right? Or even interstitial lung disease or lung injury. And then, we have to think about other things that cause respiratory distress, like heart failure, congestive heart failure, like pulmonary embolism. And then we have some other stuff that we always need to keep in the back of our mind that cause respiratory distress, like neurogenic processes. And I told you already about a case of opiate overdose that decreases the respiratory rate and causes hypoxemia and hypercapnia and so forth. And then we also talked in a different context about neuromuscular diseases like myasthenia gravis and so forth that may cause respiratory distress. So we should always have that in the back of our mind. Is it obstructive disease? Is it parenchymal lung disease? Is it lung injury? Are we talking about heart failure? Are we talking about thromboembolic disease? Are we talking about neuromuscular disease or central nervous system disease that causes the respiratory distress? Whatever be the reason, though, what do we always do in patients with respiratory distress? The number one thing we always do are ABCs first, right? We keep the airway open, right? We keep respirations open. And then the first and foremost thing, even before we do any testing at all, we give the patient supplemental oxygen. Always in a patient with respiratory distress, first thing we do after we do our ABCs and we stabilize the patient, we start to give the patient supplemental oxygen. It may be in the form of nasal cannula, or in a very distressed patient, we may have to intubate him, but we have to give him oxygen. Please don't wait until tests are done to confirm the diagnosis. Please don't send off patients to the x-ray in respiratory distress without giving supplemental oxygen. This is not the right answer. You always give supplemental oxygen, and we always give supplemental oxygen, and we're going to talk about this a lot over the next couple minutes or so, enough to keep saturation at least 88 to 92% saturation, always. We try to even above in that in certain cases, but that's the minimum. Then we go through a couple of the other stuff and to give us a differential diagnosis of what's happening and to start the treatment. And that's the evaluation process, which means getting a good history and doing a good physical exam. And the first, one of the most important things is to get from the patient or the family, is this acute or chronic? So for example, somebody that comes in with an acute shortness of breath and distress, respiratory distress, well, you're going to think about things like pulmonary embolism, like heart failure that just, decompensated. If you hear more of a chronic process and somebody says, yeah, I've had this shortness of breath now for, weeks to months, and it's only getting worse in the last couple of, days or so, there's other processes that you should think about, like chronic obstructive lung disease. People like with idiopathic pulmonary fibrosis and interstitial lung disease, they get more of a chronic process. So acute versus chronic makes a big difference in your differential diagnosis here. And the physical exam is very important. That's going to tell us a little bit more and guide us a little bit more. And the physical exam and the respiratory rate is the most important thing out of the physical exam. It's the first and most important thing in evaluating a patient with respiratory distress. Please remember that a normal respiratory rate is about 12 to 14. I know we always write on the chart the patients have normal respiratory rate about 20, but actually if you measure this patient's respiratory rate over a minute, people that have real 20, respiratory rate of 20, they have mild respiratory distress. Patients presenting with a thromboembolism commonly have respiratory rate in the low 20s, so please be careful of that. Patients that have respiratory rates above 30, they have severe respiratory distress. They have severe respiratory compromise. Those patients, you have to really look closely. You have to follow them closely. Make sure that you're evaluating that patient closely. The nurses are getting vitals every hour, every couple of hours to make sure they're not getting worse, because that's the kind of patient you may have to intubate or send to the intensive care unit. So again, respiratory rate is very, very important. Above 20 or above is mild, above 30, severe. Stay close to that patient. Beyond the respiratory rate, a couple more things we need to do, we need to get from the physical examination. So especially the lung examination. So for example, if we find wheezing and auscultation, usually that accompanies things like asthma and COPD. Localized wheezing usually suggests foreign objects or mass. Please be careful in children. Localized wheezing usually, 99.9% of the time is a foreign object. They usually probably aspirated at some point. Crackles on examination usually accompanies pneumonia. Sometimes they tell us about these fine crackles at the bases with expiration usually, and sometimes with inspiration, usually that accompanies interstitial lung disease like idiopathic pulmonary fibrosis. And normal lung examination is a very, very important finding. Normal lung examination in respiratory distress with an elevated respiratory rate, that usually signifies thromboembolic disease, pulmonary embolism, or maybe some other things like pneumocystis carinii pneumonia. It has minimal findings. This occurs usually in HIV patients, and sometimes people with central respiratory drive processes, opiate overdose or neuromuscular disease have normal exam. But for your purpose, especially the one that you're really, really concerned about is thromboembolic disease, especially in people that are high risk for thromboembolism. So after the physical examination, a couple more things we need to do. And here's where some of the questions may come on the boards, where what type of labs and when do we do things? So probably the most important thing, the most important laboratory tests in evaluation of respiratory compromise, probably the single most important test, is probably an arterial blood gas measurement. It's likely the most important test because it determines the presence and the severity of respiratory compromise. So it's probably the first thing to do even before a chest x-ray. Remember the hallmark, the definition of respiratory failure is a rise in the partial pressure of carbon dioxide and a drop at pH. A normal PCO2 is 40, so a rise above that, and a drop in pH, a normal pH is 7.4. The bicarbonate level is very interesting. In the beginning, if this is an acute process, it will be normal. Remember, because once you get a respiratory process, The compensatory mechanism is to accommodate with that, with the bicarbonate, either to get rid of the bicarbonate or hold on to bicarbonate, depending on what the respiratory process is, through the kidney. And this process through the kidney, the change in bicarbonate levels to accommodate a respiratory acidosis or a respiratory alkalosis, takes about 2 days to come into full effect. That's why when we see acute respiratory processes, in the beginning you get a big change in pH depending on the change in CO2, and then after about 48 hours you see that change. There's still a change, the patient still has change in pH, but that change, according to the CO2, is less because now you have accommodation from the kidneys from the bicarbonate. So that's important. Then we have the chest X-ray, which is a very important test. It allows us to determine the cause of respiratory failure. So for example, a patient with parenchymal infiltrates, right, you're going to think about things like idiopathic pulmonary fibrosis, if this is chronic, or somebody coming in with cough and fever, and the pulmonary infiltrates, you're going to think about bacterial pneumonia or even viral pneumonia. And then the normal chest X-ray is important, very important in somebody with respiratory compromise, because there's not a lot of things that cause respiratory compromise with a normal chest X-ray, one of them being thromboembolism. The other, as we talked about before, is central disease like opiate overdose. That would be another process, or neuromuscular disease. So please, the ABGs first, then we look at the chest X-ray to look at what's causing the process, and a negative chest X-ray along with a negative physical exam, very important. Think about pulmonary embolism. The third test that people commonly get now, and I want you to know this test because it's likely going to be asked at some point or another. It's a test that has become part of clinical practice within the last 2-3 years, when the Sentinel, some of the Sentinel cases came out, and the papers came out on this. It's called the BNP, or B-type natriuretic peptide, and the B peptide, the BNP, appears to be a useful adjunct to the clinical assessment to determine the cause of acute dyspnea in patients presenting emergently. An elevated BNP is seen in almost all cases with heart failure. The BNP is secreted when there's dilatation of the atria. So all patients with heart failure have an elevated BNP. So somebody coming in with dyspnea, they have history of heart disease, they have history of COPD, they're coming in with shortness of breath dyspnea. How do you know which one is which? On the X-ray, you can't tell the difference. You do the BNP, if it's elevated, it's from heart failure. If it's normal, then that patient is likely to have some other non-cardiac causes. Think about chronic pulmonary disease, think about other processes, and so forth. So please, that is to evaluate patients if they're coming in, if the cause of dyspnea, the cause of respiratory distress, is heart failure. It is elevated in almost all cases. Almost 100% of cases have elevated BNP. If that BNP is normal, it's almost zero chance that this is related to heart failure. Having said that, there's also some other things that they may cause elevated BNP that outside of the traditional congestive heart failure cases that we usually see in clinical practice. So for example, let me give you 2 scenarios. A patient has chronic obstructive lung disease that's severe, and we know that chronic obstructive lung disease sometimes causes right-sided heart failure. This is referred to as cor pulmonale. That patient will have an elevated BNP. So it's outside the traditional form of congestive heart failure that we think about. And then the second scenario is, what if a patient presents with a massive pulmonary embolus? Well, doesn't it distend the atria because of the pulmonary pressures increase? That patient may also have an elevated BNP. So even though a normal BNP rules out heart failure as the cause of the dyspnea, an elevated BNP is not 100% that this is heart failure. You have to think. It has to make sense in the clinical picture. So somebody, for example, that has an elevated BNP and has a history of congestive heart failure because they have ischemic cardiomyopathy and they come in and they have jugular venous distension and so forth, that BNP is elevated. That tells me this is likely heart failure. So use it in the right clinical context. Make sure that you're not looking at somebody who doesn't have a history of heart disease and now comes in with an elevated BNP. Think of some other stuff too that we just talked about. So that is how we evaluate a patient with respiratory distress. And one more point on here is how do we and when do we admit to the ICU and intubate? Now this is not a classic question for step 2, but there are some questions around this that they may ask. Not specifically when do you intubate. That's not a legitimate question for you all. But let me tell you a couple scenarios you need to know that this patient intubation, admission to ICU would be an option. So the first two make sense, right? Anybody that has persistent hypoxemia and increasing oxygen demands, you have them outside on the floor or in the emergency room, and despite you giving them, supplemental oxygen, they're still very hypoxemic, or the other patient, you increase oxygen demands day by day. Well, that patient needs closer monitoring. And the reason to admit them to the ICU is for that. And if they continue to get worse, maybe considering intubation would be an option. That's not the typical patient they're going to ask you about. If they ask you about ICU admissions, if they ask you about intubation, they're going to refer to some other patients. One of these patients would be an asthmatic patient with hypercapnia. So remember, patients with asthma, usually they get an exacerbation of asthma, and they come to us and they're breathing really quick, they're huffing and puffing, and they're healthy otherwise. They're usually younger patients, not always, but most of the time, and they're huffing and puffing and they're blowing off their CO2, so they have usually a respiratory alkalosis with a low CO2. That's what makes the respiratory alkalosis. That's the typical pattern that you see in an asthmatic patient. If an asthmatic patient develops hypercapnia, so CO2 retention, and when they develop the CO2 retention, their pH starts to drop. They start to become acidemic, respiratory acidosis with hypercapnia. It means that this patient has respiratory muscle fatigue. Please, that patient needs to be minimum in the ICU, and you have to consider intubating the patient if this persists. Then some of the non-traditional reasons that we intubate patients and admit them to the ICU is because of upper airway injury. One of the things we do is protect the airways in this case. So they may tell us about a case of a burn patient or somebody that has laryngeal edema as a complication from some medication like an ACE inhibitor, and they develop stridor and laryngeal edema. That patient you have to intubate to protect the airways. You're not doing it to give the patient oxygen, supplemental oxygen, because they're hypoxemic so much, not because there's a lung process, but because there's going to be occlusion of the upper airways, and you have to do that. In the burn patients, one of the most important questions that we ask when we evaluate burn patients, and you're going to do this when you look at the emergency department medicine stuff, is we always look in their mouth and their nose to see if there's any evidence of burn there. If there's any evidence of burn, the first thing we do is we consider intubation to protect the airways, because we know 24, 48 hours later, these patients will develop laryngeal edema and inflammation and obstruction. And then the third typical patient, they tell us about a patient who's confused for some reason or another, either because they're taking drugs, either because they have some metabolic process like renal failure or end-stage liver disease, but they are confused and they have aspiration risks. So in this patient, again, you intubate to protect the airways. And then the fourth case, they tell us sometimes that we need to know about intubation and admission to the ICU, is the typical patient with some kind of neuromuscular disease and has neurologic and neuromuscular depression. So take the patient that has Guillain-Barré's disease. Well, that's a pretty, benign disease, and most of the time, in a couple of weeks or a month or so, it goes away, right? But if the neuromuscular disease, if the neurological depression involves the respiratory muscles, that patient has to be mechanically intubated and mechanically ventilated. So any patient with neuromuscular disease that has respiratory muscle fatigue and that develops hypercapnia, this patient, you have to intubate to protect, again, the lung until the disease goes away. So again, which patients are we concerned about and which patients do we admit to the ICU and consider intubation? I told you about the persistent hypoxemia and the oxygen demands, that we all know, but think about the 4 cases we talked about: hypercapnia in asthmatic patients, upper airway injury, especially burns, and then we said about the patient with altered mental status, which you intubate to protect the airways, and then we said patients with neuromuscular disease, especially chronic neuromuscular disease that's not going away and affects the respiratory muscles. That ends our chest radiography session.